Good evening, friends. I welcome you all on behalf of our President, Federation of Family Physicians Association of India, Dr. Pragnesh Shah, and our Secretary, Dr. Pragnesh Vacharajani, who were unable to join us today. So we are here again in the new year to have another session with Dr. Tushar. We have been doing regular academic activities twice in a month. We have also started Financial Fridays, which is non-academic but related topics. So I hope you all join us and make the most of it, take benefit out of all these programs. Also a reminder for the conference in FFPI conference of Ahmedabad on 18th of February in Ahmedabad, and our national conference 2025 January 3rd, 4th, 5th at Vadodara. In the group, we have shared all the details. I take this opportunity to welcome you all and invite you all for the conferences. Now, I request Dr. Vibhakar Advaryu to introduce today's topic and Dr. Tushar Shah. Welcome you all.
Yeah, thank you, Dr. Preeti. Dr. Tushar Bhai is very well known to everybody now, and I don't think we need to waste our time on introducing him. We are here to witness the 9th webinar live with Dr. Tushar Shah, and he is going to speak to us on thumb rules in the interpretation of blood reports. May I request Dr. Tushar Bhai to start the webinar? Thank you.
Thank you, Dr. Vibhakar. Thank you so much. And hello, everybody. Thank you for joining. Mr. Rahul actually will help me with the presentation. So, Rahul, thank you so much. Our topic is thumb rules in interpretation of blood reports. As you know, all rules have exceptions. So there will be exceptions to some of the rules that we talk about. But these are good rules to follow. And I have tried to take only those areas which are fairly common. Therefore, there will be many things that you will hear which are already very well known to you. So for some of you, it will be totally a full revision. But I'm hoping that many of you will get new points to follow for their OPD practice. Rahul? I've taken very random selection of blood reports. So please bear with me. It is not in an organized fashion. I like to keep things random because I think the recall value and the attention span is better preserved by doing things randomly. So here, first of all, is uric acid. The commonest mistake made by us family physicians is that we give importance to asymptomatic hyperuricemia of, say, 7 or 8 milligrams percent. Please remember that in asymptomatic patients, meaning patients who have never had gout or who do not have uric acid nephrolithiasis, you should not treat unless the uric acid is 9 at least. And some literature gives the uric acid value cutoff as 11 if the patient has a normal kidney and no symptoms. If the eGFR is less than 60, that is the patient has stage 3 CKD or more, then uric acid should be treated even if it is above 6.2. So uric acid levels should be maintained in patients with CKD at 5 milligrams per deciliter. So these are the two reasons to start urate lowering therapy. Uric acid asymptomatic, no CKD, more than 9. Uric acid in CKD if with GFR less than 60, if the uric acid is more than 6 or 6.2. So this is one about uric acid. May I have the next slide, please, Rahul? Now, one important area of discussion is the pre-diabetes segment on blood reports. As you know, impaired fasting glucose, impaired glucose tolerance, and HbA1c. These three are considered tests for both diabetes and pre-diabetes. IFG is defined as 100 to 125, IGT 140 to 199, and a pre-diabetic so-called HbA1c is 5.7 to 6.4. Now, it is very important for us to know that The treatment of pre-diabetes with pharmacotherapy is an area of major controversy. Who should we start metformin or even other drugs on is a matter of debate. The more important thing is motivation. So motivation is more important than medication in pre-diabetes. It is very commonly seen that metformin is very easily started in these patients. Please don't do that. Another very important thought that I have is that the HbA1c test as a screening process, screening test for diabetes diagnosis or for pre-diabetes diagnosis is a useless test. I'm using a very strong word, useless test. For diagnosis, not monitoring, for diagnosis of diabetes or pre-diabetes, I think you should not only rely on fasting glucose and postprandial or post glucose uh, blood test, because you will often see in your practice that fasting glucose is 90, post lunch is 140, and HbA1c is 6.4. This can happen again and again, and I don't think we should give credence to HbA1c in labeling the patient as pre-diabetes. Even diabetes diagnosis based on HbA1c alone is full of fallacies. So if a patient has HbA1c of 6.5, which would be a criterion for diabetes, but if the fasting and post-lunch sugar are repeatedly normal, please do not start therapy for HbA1c. That is an important thing. I also feel that the point of care HbA1c, the HbA1c kit that is available, the machine that is available uh, in clinics, I have extremely low reliance on these machines. So I'm hoping that most of us will fall back on fasting and PP for diagnosis, and HbA1c maybe for monitoring. Yes. Next slide, please, Rahul. Let me talk about some thumb rules in liver function tests. If you do an LFT, what are the tests that you look for, that you get? You get bilirubin, SGOT, SGPT, also known as AST/ALT, another enzyme called GGT, then alkaline phosphatase, total proteins, that's serum proteins, including albumin and globulin. And sometimes you will get prothrombin and INR. Isolated GGT elevation is a feature of alcoholism. Isolated alkaline phosphatase elevation does not happen in liver disease. It happens in bone disease, most commonly low vitamin D. Isolated indirect hyperbilirubinemia is either a feature of Gilbert syndrome or low vitamin B12, the commonest two causes of indirect hyperbilirubinemia. If alkaline phosphatase and GGT are both elevated, one should think of a space occupying lesion or some obstruction in the biliary system. So these are the peculiar rules of thumb of liver function tests, isolated abnormalities. Rahul, next slide, please. We stay with liver function tests, and this time some rules of thumb in acute febrile illness and liver profile. If we often do SGOT and SGPT in liver in acute fevers, the rules of thumb are enteric fever will have SGPT elevation more than SGOT elevation. Malaria will also have SGPT more than SGOT elevation, with sometimes indirect hyperbilirubinemia due to hemolysis. Dengue will have SGOT elevation more than SGPT elevation, and the reason of that is the SGOT is also a muscle enzyme, and dengue affects muscles. So SGOT elevation will be greater in dengue. In leptospirosis, SGOT, SGPT will be marginally elevated, but bilirubin elevation will be disproportionate to the SGOT, SGPT elevation, much higher than the SGOT, SGPT elevation. Chikungunya liver profile should be normal. Maybe the next slide, Rahul. Now, what happens to platelet counts in acute fever? Some rules of thumb. Dengue, malaria will often have significant platelet count drop, thrombocytopenia. Enteric fever and chikungunya both can cause a lower than normal platelet count, but that will be hovering around 1,50,000, maybe 1,30,000. So enteric chikungunya, a low platelet count does not rule out enteric and chikungunya. And of course, elevated platelet count, especially with elevated WBC count, is a feature of bacterial infections like pyelonephritis and pneumonia, because platelets are also an acute phase reactant, especially related to bacterial infections. Rahul, may I have the next slide, please? Now let's come to ESR. ESR is very commonly tested. 2 or 3 pointers about ESR. First of all, ESR can be a feature, a high ESR can be a feature of aging. So the rule of thumb is, though we say, the lab reports will say ESR up to 20 is normal, etc. The thumb rule is, in an elderly male, age divided by 2 is the upper limit of normal ESR. So in an 80-year-old male, ESR up to 40 should be considered normal. In an elderly female, age plus 10 divided by 2, that is in a 80-year-old female, 45 will be the upper limit of normal ESR. This is important because ESR can often be high in the elderly and should not make us unnecessarily investigate when the patient does not have any symptoms to be investigated. ESR, another feature, important thing is about ESR versus CRP. Remember, CRP is an acute phase reactant that rises faster than ESR. So if you are ordering an acute phase reactant in an acute illness, like say influenza, please order CRP. Commonly, one would do it to differentiate upper respiratory tract features of infective origin from upper respiratory tract features of allergic origin. So if you are looking for differentiation, do the CRP, not the ESR. CRP will be high in viral infections, for example, influenza, but may not be or will not be high in allergic rhinosinusitis, or for example. So that would be the function of CRP. May we have the next slide, please? In the US, 60% of erroneous prescriptions of thyroxine are to patients with subclinical hypothyroidism without real indication of giving thyroxine. Now, what does this mean? Subclinical hypothyroidism, as you all know, is when the TSH is between 5 and 10. If you see a report between 5 and 10, the thumb rule is do not start a thyroxine tablet for this, except in situations which I'm going to describe. So the thumb rule is most patients of subclinical hypothyroidism do not require thyroxine. Now, which patients will require thyroxine? One, the decision depends on age. The older the patient, the more is the TSH normally. Therefore, maybe up to a TSH of 10 in a patient with normal T3, T4, what we call subclinical hypothyroidism. If the patient is elderly, say more than 75, you will not prescribe the thyroxine medicine. Why in the elderly would you not prescribe? Because in the elderly, thyroxine can cause osteoporosis and atrial fibrillation. So, older the patient, the more leeway you give the patient. While subclinical hypothyroidism is defined as 5 to 10 TSH, normal T3, T4, some patients will have 10 to 15 TSH and normal T3, T4. Now, if the TSH is 12, for example, T3, T4 are normal. In an elderly patient, you would refrain from prescribing thyroxine, even these patients. Unless the T3, T4 falls, you will just monitor them and not prescribe. Now, that is age. Now, the second thing is presence of anti-TPO antibodies, thyroid peroxidase antibodies. If the antibodies are positive, which means that the patient has a tendency to autoimmune thyroid disease, T3, T4 is normal, TSH is 5 to 10. In these patients, will you start thyroxine? Many authorities say they will start. Do remember, you can start, especially in a patient who has some symptoms, meaning some features like obesity, menstrual disturbance, hair fall, etc. But what is the statistic? Patients who have antibodies and subclinical hypothyroidism, the chances of their becoming frank hypothyroids are about 4% per annum. So, so this is not a large chance of becoming frankly, and many of them will never become hypothyroid. So you will have to be careful about who to give. So think of other situations. So in which situation will you be more keen to give in the presence of TPO antibodies? One, in patients who are, say, overweight, have symptoms which are uh, of hypothyroid. Definitely in patients who have imminent pregnancy, if they're going to plan pregnancy, if the anti-TB antibodies are positive, then even in a TSH of 4, you will give thyroxine. If the patient has family history of autoimmune disorders, you will give, if the TPO antibodies are present, you will give thyroxine. So these are some, there is no, there is no clear cut recommendation or guideline about subclinical hypothyroidism therapy with thyroxine. Still, so we will have to decide case to case. But basically, the tendency is to overtreat, and that tendency we may want to avoid. Rohan, next slide, please. Uncontrolled hypothyroidism also causes high LDL cholesterol. Often you will see a patient who comes with a complete health checkup report. The TSH is 21 and the LDL, not the total cholesterol, the LDL is 275, for example. Do remember that the LDL cholesterol goes very high in uncontrolled hypothyroidism, and therefore you should wait till the hypothyroidism is controlled to check the LDL again and then treat as per the guidelines for LDL. So this is something that is again done incorrectly in hypothyroid patients. Also in hypothyroid patients, do remember there are some blood tests that you will see which are abnormal. For example, hyponatremia, sodium will be low in hypothyroidism. CPK will be high in hypothyroidism. Prolactin will be high in hypothyroidism. So these things again should normalize as you treat the hypothyroidism. Rohan, the next slide, please. That brings us to the LDL cholesterol. The most incorrectly prescribed cardiac drug has to be a statin. The most inappropriately prescribed cardiac drug has to be a statin. So when you see a blood report of lipid profile, and if the patient is, say, a 65-year-old non-diabetic male, and if you see an LDL cholesterol of 155, LDL 155 in a 65-year-old non-diabetic male who has never had any myocardial infarction or other atherosclerotic cardiovascular disease, you will be tempted to start a statin, but please don't start unless one of these criteria are satisfied. Do not start statins. The thumb rule is to treat only in 4 statin benefit groups. 1, patients with clinical ASCVD. What is ASCVD? Atherosclerotic cardiovascular disease. What are the areas of atherosclerotic cardiovascular disease? Coronary artery disease, cerebral vascular disease, peripheral vascular disease, renal artery stenosis. These are atherosclerotic cardiovascular diseases. What is the meaning of clinical ASCVD? If you do a CT angio of a patient who's asymptomatic, and the CT angio shows 30%, 40% lesions on the coronary arteries, this is not a clinical ASCVD. So here, still, statins are not recommended. So if you have a clinical ASCVD and the patient's LDL is anything, you will start a statin. If the patient's, say, for example, if the patient's LDL is 75, you will start a statin. You want a target of at least 70 of a patient with ASCVD. The second benefit group, statin benefit group, is an absolute value of LDL above 190. If you get a patient who comes with a lipid profile, asymptomatic, no diabetes, no ASCVD, and the patient is 40 years old, and the patient is LDL of 190, you should start a statin. Now, here the age limit has not been specified. If a 25-year-old comes with 190, you should start a statin in a 25-year-old also, because atherosclerotic begins at a very early age. Now, patients with age of 40 to 75 with diabetes and LDL of more than 70 are again the third statin benefit group. What does this mean? Patient has diabetes. Patient is at least 40, but not more than 75. Patient does not have atherosclerotic cardiovascular disease. This is the category where it does not have ASCVD. If a patient is in this category, you will give a statin to keep LDL below 70. Now, why not below the age of 40? Why don't we give type 1 diabetics who have LDL more than 70 a statin? That is because the younger you start statin in diabetic patients are without ASCVD, the greater the chances of complications of statins, including muscle complications. So below 40, the benefit has not been yet established. Similarly, above 75, if you detect diabetes, don't start a patient as primary prophylaxis for with statins. Meaning, what is primary prophylaxis? Where there is no ASCVD yet. So you have a 75-year-old who has come with diabetes and first time detection, and the LDL is 90. Will you start a statin in this patient after the age of 75? You will not. But if the patient was 65 or 70 or 74 when diabetes was detected, and he or she was put on statin, you will continue the statin beyond 75 in diabetics for primary prophylaxis. But I'll repeat, in a patient who is newly diagnosed after 75 with diabetes, you will not start a statin. That is the recommendation. The reason again is the benefit has not been established in studies. Now, the fourth category is patients between 40 and 75 years with a 10-year atherosclerotic cardiovascular disease risk of more than 7.5%. As you know, there is a cardiac risk score made by the American Cardiology Society. If you have and it's easily available on a Google search, you just have to type cardiac risk score. If the risk score of 10 years, the risk score depends on presence of diabetes, presence of blood pressure, the cholesterol value, the smoking, etc. If the risk of a major event is more than 7.5% over next 10 years, this patient deserves a statin. Again, the target LDL is 50% of baseline level or less than 70 milligrams per deciliter. Now, why is this age limit 75 only? Because if you are 76 and if you try to calculate your ASCVD score, it will always be more than 7.5%, almost always. The benefit is not established because remember, the benefit of statin accrues over years. It is not an immediate benefit in the next 6 months or next 12 months. It is a benefit that is over years. So hence, the older the patient, the lesser will be the benefit. Rahul, next slide, please. So again, as I said, avoid statins for primary prophylaxis in person age 75 or more. Rahul, next slide, please. Now you are seeing reports, blood reports, and you see the CBC and you see hemoglobin, and then you see one. After you see hemoglobin, the first thing that you always must see is the mean corpuscular volume, the MCV. Normal MCV is between 80 and 100. Less than 80 is called microcytosis. More than 100 is called macrocytosis. Whenever you see high MCV, the commonest thing that we think of is B12 or folate deficiency. However, the rule is you must think of the other causes beyond B12 or this, meaning you should think of alcoholism and ask history of alcoholism in these patients. You must investigate for liver disease in a patient with high MCV. And you must check the TSH in a patient with high MCV because hypothyroidism can cause high MCV. Next slide, please, Rahul. Rahul, next slide, please. Yeah, thank you. No, previous, thank you. If you see a low MCV, that means there is microcytosis. What is the first thing to see? The thumb rule is, as I said before, after you see MCV, especially in a low MCV patient, look at the RBC count. So first you see the hemoglobin is low, you see MCV is low or high, you look at the RBC count. Especially in low MCV, the RBC count becomes very important for the differential diagnosis. Two common causes of low MCV, that is microcytic anemia, are iron deficiency anemia and beta thalassemia trait. Two commonest causes. It is extremely easy to suspect one or the other by just looking at the CBC. A low RBC count in the presence of microcytic anemia favors iron deficiency. A normal RBC count or even a higher than normal RBC count in a patient with microcytic anemia favors beta thal trait. This is the thumb rule. You also know about the Menzer index, which you can calculate. But I think if you just look at these two features also, you will be able to order the test for thalassemia trait or iron deficiency anemia. If you are thinking of thalassemia, you have to ask for hemoglobin electrophoresis for abnormal hemoglobins. If you are looking for iron deficiency anemia, you will have to look for outer serum ferritin or serum iron studies with transferring saturation. So this is microcytic anemia. Rahul, may we have the next slide, please? Now, this is a very important thumb rule. A patient comes with a hemoglobin of 7 and the MCV is normal. Normal MCV is between 80 and 100. Hemoglobin of 7, MCV is 85. What do you do? This normocytic anemia is typical of chronic disease. Like patients with CKD will have such an anemia. Patients of rheumatoid arthritis will have such an anemia. Normocytic anemia, where MCV is normal. However, the most important thing for us, especially in the younger patient or patients who do not have chronic diseases like CKD or rheumatoid arthritis, in these patients, in the normal MCV, please think of dimorphic anemia. What is the meaning of dimorphic anemia? It means patients have both iron deficiency and B12 deficiency. This is called dimorphic anemia. Now, iron deficiency will push the MCV towards microcytosis. B12 deficiency will push the MCV towards macrocytosis. And if both are coexistent, which is common, then you will have a normal MCV. So don't miss this. To diagnose this again, you will have to do probably both an iron level and a B12 level. Rahul, next slide, please. We'll change tracks a little bit and we go to PSA. In men, screening tests for cancer in general are principally lung CT scan, what is called low dose CT scan in chronic smokers, colonoscopy in patients who are above age 45 or 50 or with family history of colon cancer. These are the two principal cancers screened in men. The third cancer screened in men is the prostate cancer. Now, over the decades that when I was young, PSA was routine screening test. Now there is a lot of debate about whether we should do PSA at all or not do it at all. So the thumb rule is that individual more than 70, if the individual is asymptomatic, do not do PSA. Why is it so? It is because diagnosing prostate cancer at this age of 70 or more does not change the prognosis of the patient. Early diagnosis does not help. What is the meaning of asymptomatic individuals? Remember, in prostate cancer, the symptoms are not urinary. The symptoms are due to metastasis. So if the patient has backache, for example, which is a feature of prostate cancer, then maybe if you're investigating backache, you will do a PSA. But in a patient who is asymptomatic related to metastasis, you will not do a screening test for prostate cancer in those above 70. Now, in individuals who are between 40 and 69, the current recommendation, which may change over the years, is do a PSA if the patient is, even if the patient is asymptomatic, where the father or the brother have had prostate cancer. First degree male relatives with prostate cancer, these persons, individuals, if they are between 40 and 69, you should do a PSA to screen for cancer. Now, this is a recommendation, not in patients above 70. So if we have a patient of 75 years old whose brother has been detected with prostate cancer recently, you don't do the PSA in this 75-year-old. That is the recommendation. Rahul, may I have the next slide, please? If PSA is between 4 and 10, now you have done PSA, or somebody comes to you with a PSA report, and the PSA is less than 4, usually it is normal. If the patient is between 4 and 10, the thumb rule is do a digital rectal examination or ask somebody to do it and do a free PSA estimation. There is a thumb rule. A free to total PSA ratio of less than 0.11 favors malignancy. And then you can go ahead with other investigations. So I'll repeat. Do a DRE, ask a person to do a DRE, that means digital rectal examination. If you find a nodular prostate on a rectal examination, then you will probably go in for more tests. And if you find a free PSA, which is very low, less than 11% of total PSA, then you will go ahead with further tests. The further testing used to be always prostate biopsy. However, there is a move towards doing an MRI of the pelvis with contrast rather than doing a biopsy before the biopsy, because an MRI can reliably predict or rule out malignancy of the prostate. So, a relatively non-invasive investigation rather than a biopsy. Okay, Rahul, next slide, please. Another thumb rule, which is very, very important, and this is a very disturbing thing that is happening currently. We should not allow laboratories to do serum tumor markers as part of comprehensive packages. We all have patients who will say, okay, Dr. Saab, I will want to rule out cancer in my body. Now, we wish such a thing was possible. However, what you should advise is do a CBC, ESR, renal profile, liver profile, etc. Do an X-ray test, a sonography, do a mammogram in women, do a pap smear in women at appropriate age, do a colonoscopy if necessary. This is, you will not do CA 125, CA 19.9, PSA in inappropriate patients. All these tumor markers, which are blood tumor markers, alpha fetoprotein, are not a part of routine testing, should not be. The reason is the patient also often come with, say, an alpha fetoprotein, which is 4.5, where 4 is the normal, for example. And they will have restless nights, sleepless nights, thinking of cancer. And now, obviously, you know that slightly elevated levels are normal, even in CA 125 or carcinogenic, CAA. These levels of borderline elevation are harmful. They will lead to more investigations and panic. So, no tumor markers in health packages, including PSA. PSA, as we saw, very selected patients, not everybody. Rahul, next slide, please. Now this is an area again which is fraught with difficult decision making for us. We see a vitamin D blood report, and what are the thumb rules that we should follow? Vitamin D below 12 is definitely deficient. Vitamin D above 30 is definitely sufficient. These are the thumb rules. Between 12 and 30 is the gray zone, and there is a lot of disagreement there. So, vitamin D, what is normal, is still debated. Many nutritionists will tell you, okay, we need at least 50 nanograms vitamin D. Some will tell you we need 60. Now, all that is based on very small, uh, insignificant studies. So, our job is to keep it at 30 at least, and that should be sufficient for us. Next slide, please, Rahul. Another important dictum to follow is if a patient comes with a vitamin D level which is low, don't prescribe vitamin D, don't give additional injection without knowing what vitamin D formulation the patient is taking. For example, a capsule of Bio D3 Plus, a tablet of Shelcal CT, or capsule of Shelcal OS, all these contain the active 125 dihydroxy vitamin D. The vitamin D test that we do in blood is not 125 dihydroxy, it is 25 hydroxy vitamin D. So, if the patient is taking a active formulation and the inactive form is tested in serum, then do not consider a low serum value as deficiency. The patient's active form will never be estimated unless you ask for an active form estimation of 125 dihydroxy. So just take care of finding out the formulation that the patient is taking. Next slide, please. You see a vitamin B12 report. The vitamin B12 is 140, and it is low. Your debate is whether you treat this patient as nutritional vitamin D deficiency because the patient is vegetarian or predominantly vegetarian, or think of pernicious anemia and therefore give a higher dose of vitamin B12. How do you know whether this is pernicious anemia or not? The patient has neurological features like peripheral neuropathy, subacute combined degeneration of the cord with paraparesis, dementia, cognitive impairment, then pernicious anemia is more likely than just nutritional deficiency. If the patient has concomitant autoimmune conditions like hypothyroidism of Hashimoto's thyroiditis or hyperthyroidism of Graves' disease or vitiligo or type 1 diabetes, if the patient is low B12 with an autoimmune condition, then probably the patient also has pernicious anemia because autoimmune conditions often occur together. Pernicious anemia, as you know, is an autoimmune condition. Of course, the better method to detect pernicious anemia as the cause of B12 deficiency is to test for antibodies to parietal cells or intrinsic factor. So there are two antibodies, intrinsic factor antibody and parietal cell antibody can be checked in blood. They have variable sensitivity and specificity, but they may be able to confirm pernicious anemia. Next slide, please. This is a very important thumb rule again. High triglycerides more often than not, don't require pharmacotherapy. Most persons will not require pharmacotherapy. Now, I put high triglycerides in inverted commas because what is high triglyceride in terms of causing pathology? We have this, the labs give 145 or 150 as the upper limit of normal. That is probably incorrect, and the labs should change their method of giving normal. Just like LDL is abnormal depending on the clinical situation of the patient. For example, in LDL in diabetes is abnormal even at 80. An LDL in patients with severe atherosclerotic cardiovascular disease is abnormal even at 65. And an LDL is normal up to 180 in absolutely normal individuals. Similarly, high triglycerides are depend on the condition of it. For example, in a patient who has had pancreatitis due to triglycerides in the past, even a level of 500 cannot be tolerated. If the patient has high triglycerides in the presence of aggressive atherosclerotic cardiovascular disease, even a level of 250 or more will not be tolerated. So high triglycerides are dependent on the pathology or the concomitant illnesses of the patient. We often start triglyceride therapy with fenofibrate at levels of 190, 220 triglycerides. Don't do that. Pancreatitis due to triglycerides typically occurs if the levels go beyond 1000. But if you have even one episode of pancreatitis in a patient and then you detect triglycerides to be high, this patient deserves lifelong fenofibrate and you should target the triglyceride levels below 250. If the patient has aggressive atherosclerotic disease, you will target it below 250 again. If the patient has significant uh, NASH, non-alcoholic steatohepatitis, you may want to target the triglyceride below 250. Again, not an area with clear-cut guidelines. So don't unnecessarily prescribe your fenofibrate. Next slide, please. When you see a cholesterol report, lipid profile that is, you will find that the LDL cholesterol has been tested in either the direct method or by the Friedwald formula. How do you know that the method, the testing has been done in the calculated manner? Calculated LDL is the bottom line. If you can see, calculated LDL is total cholesterol minus HDL minus 1/5 of triglycerides. This is called the Friedwald formula. This is a cheaper test. When you ask for lipid profile with calculated LDL, the cost is about 200 or 300 rupees less. However, there is a problem with this formula. Let's take an example. If the total cholesterol is 200, HDL is 40, triglycerides is 200, then what will be the calculated LDL? It will be 200 minus 40 minus 1/5 of 200, that is 40. That means 200 minus 80 or 120 will be the LDL. Now, this is a fairly accurate uh, uh, calculation of LDL. If your triglyceride is 400, total cholesterol is 200, HDL is 40, triglyceride is 400, 1/5 of that is 100. So what will be the LDL? It will be 200 minus 40 minus 100. That means the LDL will be 60. Now this is a false LDL report. So if the triglyceride is high, textbooks say that higher than 400 should not be considered in the calculation. I believe that triglyceride more than 300 will give an erroneous LDL report. So in patients who have a high triglycerides, you must ask for a direct LDL cholesterol test, which will be a little more expensive. If you cannot get a direct LDL test because of non-availability or because of cost, then in the same patient, you will do not the calculated LDL, but you will calculate for non-HDL cholesterol. Total cholesterol minus HDL, that is 200 minus 40, 160 is called the non-HDL cholesterol. And non-HDL cholesterol is usually 30 more than the true LDL cholesterol. So you may judge your therapy based on the non-HDL cholesterol. Maybe the next slide, please, Rahul. Oh, that is the end of the show. I'm sure there have been questions, and I'm sure that because the information is quite a lot, there must have been some gaps in focus. So if there are any questions, please post them on your YouTube video, or Dr. Vivakar please take over for the questions and answers.
So thank you for the excellent session. Dr. Vibhakar, are you taking, can you say anything?
I don't see any.
Yeah, there are a
questions.
few questions on YouTube, sir. One Dr. Shobha is asking, how about in young adults? That's all she has told. She probably means the HbA1c in young adults.
Maybe I'm hoping that it might be a statin related question.
Or it was right in the beginning of your talk, or it is thyroid.
Okay. We'll have to clarify that because young adults in uric acid will be different and thyroid will be different, etc.
There's another question, sir. Isolated increase in alkaline phosphatase, vitamin D above 30. What could be the causes?
A recent fracture, for example, a recent orthopedic surgery, for example, can cause an elevation of alkaline phosphatase isolated. A bone tumor, osteogenic sarcoma, osteosarcoma that is, can cause an elevated alkaline phosphatase. So yes, then you'll have to investigate the skeletal system for the diagnosis.
So I have a question. You said in the beginning that HbA1c not for diagnosis. Okay, but we can have a HbA1c value to warn the patients or to keep them pre-warned and prepared. Medication need not be given, but at least for lifestyle improvement.
Yeah, agreed. I agree with that. That it's like you cause some degree of panic and anxiety to be able to motivate them. As I said, motivation is important. But I do feel that fear should not be the motivation. And fear from a false report should definitely not be the motivation. So I don't know whether we should do that. While you know how CGM is being used, CGM is being used to inculcate motivation through fear, continuous glucose monitoring. There is a significant abuse of CGM, and that is being used to kind of every morsel the patient eats, the patient feels, okay, my CGM will now be higher, or will show higher readings. I don't think that is a method of you're causing mental health problems rather than solving significantly physical health problems. So I would not do that. Yeah.
Yes, sir. So another question on thyroid. Subclinical hypothyroid, fine, but you do get a lot of equivocal or very confusing reports in thyroid. Can you give us some clarity on that? See, we'll see a normal TSH and high T3 or T4. We do get a lot of values which are not very clear.
Yeah. So one thing is about, of course, the if you get a normal TSH and a low T3, T4, meaning hypothyroid T3, T4, but normal, you have to consider the report to be wrong. If you get a high T3, T4, but a not suppressed TSH, you have to consider the report to be wrong. In hypothyroidism, TSH has to be abnormal, not T3, T4 first. And hypothyroidism, TSH will be suppressed before T3, T4 rise. So you must consider those reports as wrong. We must have the courage to say, okay, to the patient, I think this report is wrong, and let us repeat it in another lab. And this is so frequent that the reports are wrong, including HbA1c or thyroid risk. About discrepancy, what happens? One very interesting area is subclinical hypothyroidism is a TSH of 10 to 15 with normal T3, T4. Do you label it as subclinical hypothyroidism or as frank hypothyroidism? I would label it as subclinical hypothyroidism in the older person and as frank hypothyroidism in the younger person. Now, this is an interesting area, controversial area. My statement may be incorrect, but the older the person gets, the more leeway you give to the TSH, the more leniency you give to the TSH. At the same time, don't ever give leniency to low T3, T4 in a patient with hypothyroidism. Once T3, T4 are lower than normal, even one of the two, you must replace. But TSH being high should not be the only reason to replace in most elderly patients. Above 15, no controversy. And you will almost never get TSH above 15 with normal T3T4. TSH above 15 and low T3T4 will always be together. Yeah.
The isolated hyperbilirubinemia. How do we rule out or how do we confirm Gilbert's?
Gilbert's cannot be confirmed or ruled out. Gilbert's basically, there's no test, I think, for the enzyme deficiency that Gilbert's has, at least not in the clinical realm of day-to-day practice. What I would do is look for patients' earlier reports, if any. Also look for the fact that the bilirubin, first time report, if the bilirubin is not more than 5, because Gilbert's usually does not cause bilirubin more than 5. And if the bilirubin is indirect predominantly, and if the other liver functions are normal, and if the hemoglobin is not low, that means there is no hemolysis causing the indirect hyperbilirubinemia, then I would probably presume Gilbert's, tell the patient that this looks like Gilbert's, and ask them to repeat a bilirubin after 6 months or 12 months. If the bilirubin remains similarly elevated, the indirect bilirubin, then I'm fairly certain that this is Gilbert's. There are other conditions, genetic conditions like Crigler-Najjar, where again, like Gilbert's, the bilirubin is high, but those are much rarer than Gilbert's. So Gilbert's would be the commonest diagnosis.
So you repeat it after 6 months?
And if the bilirubin is still 5 and indirect is still 4, then I can confidently tell the patient that since no other abnormality is apparent on LFT or hemoglobin, you have Gilbert syndrome. And the only thing that you have to tell a Gilbert syndrome patient is that if you fast, like in Ramzan, if you fast, then your Gilbert's can go high. If you get bilirubin can go high. If you get gastroenteritis, you get dehydrated, your bilirubin will go high. You will get clinical obvious icterus. Again, not something that you have to be scared of. And you should not be unnecessarily treated for, jaundice, like hepatitis A or E, etc.
I don't treat it, but I repeat it after 1 month.
Yeah, so you will get the same reading after 1 month, right? So if the report is consistent over time, then this is Gilbert's.
Okay, thank you, sir. Thank you very much. There is no more clarification on that doubt which Dr. Shobha put. And there are no more questions on the YouTube. Thank you for an excellent session. And this is a very relevant topic, how to interpret reports. Many a time we see a lot of, and today it's the age of health checks, corporate health checks, every other person is doing. So there is a lot of clarity on so many areas. Thank you very much, sir. Thank you, Dr. Vibhakar. Thank you, Rahul and Rushil. And last but not the least, yes, thank you very much. And thank you, last but not the least, all the audience and all our viewers who joined us on the YouTube. Thank you all very much. Looking forward to more from Dr. Tushar.
Thank you so much, Dr.